be formally starting. We just wait for around 7:05 to 7:10.
Yes, that's okay. That's okay.
That's है ना? So
Yeah.
the-
Just एक बार share करके देख लें slides क्या? मतलब just the first slide.
right, that I'll do.
Yeah.
हाँ, मैं भी करती हूँ, है ना? And thank you very much, Sabha, for joining.
अच्छा सबा क्या?
I could see. I think Sabha's ID. Right.
So I've just sent you a request.
Yeah. Yes.
Yeah, now I think I can share.
Sabha,
Yes.
Sabha is with us.
Oh, great. Hello, Sabha. Can you see my screen now?
Yeah, it's very well
Oh,
visualized.
okay, good. So I'll stop share now. I can
Mhm.
just, that's better.
Right. So I just take a pause of 5 minutes. The
Yes,
time
yes.
my team is doing some background work, right?
Good.
Yeah, thank you,
Yeah, see, just
just 5 minutes. We'll meet again.
sure, sure, sure.
There was some troubleshooting. I'm extremely sorry for that. So,
It's okay.
friends, thank you very much for joining on this very, very good evening to everyone. For those who are new to this program, yeah, I could see Poonam. Thank you very much, Poonam, for joining us. I could see Sabha. I think
Sorry.
Sabha, some disconnect. Yeah, Sabha is also there.
Hi,
Thank you
hi,
very much,
Sudhi.
Sabha.
Hi,
Hi,
Sudhi.
hi, Sabha. Thank you very much for joining. मेरा
Hi,
दिन बन
hi.
गया. Thank you very much. This evening
Hey,
is
nice.
really going
Hello,
to
Dr. Sabha.
so
Hello,
many
ma'am. Hello, ma'am. So
stalwarts
nice
in
to see
thyroid
you.
surgery that are
Same
joining
here.
today.
Hi,
Hi,
Sudhi.
nice.
Thank you.
Uh,
Thank you for inviting. Hi.
yeah. Okay, fine. So now I'm formally starting the meeting. And for those who are new to this program, Brandos is the Breast and Endocrine Society of Western UP. Since myself, Dr. Sudhi Agarwal Kambuj, I'm a breast and endocrine surgeon from Meerut, and which is a part of Western UP. So this was my initiative. Around 3 years back, we started this platform where on a monthly basis, on the last Friday of the month, we discuss about breast and endocrine related problem. So on even months, we discuss about breast related problem. On odd months, we discuss about endocrine related problems. So this is an online platform where from the comfort of your home, you can join. All those who are eager to learn can join from the comfort of their home and learn something new, something very, very practical to their specialty. So through this program, we pick a clinical problem. We discuss about that clinical problem in detail with the help of actual images, videographs, and other things, with the help of expert to understand about the basics of that particular clinical entity, the problems that we face, and the solutions or the management, so that at the end of the program, we are much wiser and intelligent in dealing such type of clinical problems if it happens in the future, right? So there are various formats, and one of which we invite the specialist and we discuss about this, and today we are going to that, and I'm very, very, very excited. Many of my good friends who are great thyroid surgeons, great laryngeal surgeons who are with us today. So talking about the today's program, but before that, I would like to introduce our faculties. So our one of the prominent speakers, we have two speakers today, and we have around 5 to 6 faculties. So our key speaker is Dr. Kranti Bhavna, who's a very good friend of mine. During our training
Amen.
days, we had a very good connect, and all thanks to Brandos that because of this forum, we are now connecting again after such a long time. And she is
Thank you
now
so much.
senior professor in Department of ENT, AIMS Patna, and she is passed out from SGPGIMS Lucknow, a dynamic personality, a great academician with leadership quality, and she is the membership, and she leads into so many forums, and I really look forward to learn from you, Bhavna. Thank you very much for joining today.
Thank you so much
Yeah,
for such kind words.
yeah, you deserve.
No,
And
no, thank you.
second speaker is Dr. Sherlyn Karketa, and just hold on, please. So Dr. Sharlene is a speech therapist, and she is the founder of Rahul Speech Therapy Center, and which is a very, very prominent and center for speech rehabilitation in Meerut. And we are fortunate that we have his husband, Dr. Rahul, is also a speech therapist. And I'm very much thankful. Thank you very much, Charlene, for joining us today. And I'm looking forward to learn a lot from you, especially about the speech therapy, which we advise to our patients. With us, we have faculties, Dr. Sabah. Dr. Sabah needs no introduction, especially in our endocrine fraternity. And he's the senior professor, an additional professor in Department of Breast and Endocrine Surgery at SGPGIMS Lucknow. And a very good friend of mine, again. He's a great academician, of very good leadership quality. And I used to learn from him since our teaching days. And today he's with us to share his experiences along with our speakers, our expert panel. Uh, Dr. Poonam Joshi is with us. And I'm so glad that Poonam has joined. She's also my friend from KGMC. And right now, she is the senior professor and surgeon in Department of Head and Neck Surgical Oncology at Tata Memorial Hospital, TMH, Mumbai. And I used to see her YouTube videos, the way she used to teach, and I'm really proud to have her with us today. And I'm looking forward to learn a lot from you, Poonam. Thank you very much for joining.
Thank you
so
so much, Sudhi, once again.
So, and our other faculties are Dr. Vishal Saxena, sir. He's a senior surgeon, a secretary of ASI Meerut, and he does a lot of thyroid surgery. He's an oncosurgeon also, and he's with us tonight. Uh, and we are looking forward to learn a lot from you, sir. He is a director of Optima Hospital, a very dynamic and a great personality. And we have Dr. Sumit Upadhyay, who is a senior ENT surgeon. He heads the Department of ENT at Newtima Hospital, Meerut. And thank you very much, Dr. Sumit, for joining us today. Thank you. And with this, we know a very brief introduction and some of the experiences that I would like to share before we actually start the program. Uh, uh, we with uh, Through a safe thyroid surgeon, we know thyroidectomy is safe. Like with an experienced thyroid surgeon, we often say like this. But somewhere there is something which always bothers us. No matter how experienced we are, but there is always a chance of laryngeal injury, because the more experience that you gain, the more complicated cases that you deal, be it malignancy, be it large goiters, the chances of laryngeal injuries, so particularly the laryngeal nerve injury, is always there. And that is why we talk about using neuromonitors, and we try to invest. And many surgeons I know, they are using neuromonitors even in small goiters also. So today we may not be talking about neuromonitoring and other thing. What we are talking about, that this is a common problem, be it temporary, be it permanent, but laryngeal injuries due to any reason is a common problem. And in today's forum, today's seminar, we are going to learn what are the basics of laryngeal injury, why it happens, how we as a surgeon should identify intraoperatively, postoperatively, and how should we rehabilitate, what are the various parameters, practical aspects which we must keep in mind to manage such cases. So now, without taking much time, now I switch over to you, Bhavna, and we can start our presentation. I give you the admin rights.
So am I audible?
Yeah, you are very well audible, Bhavna.
Okay, good. So I'll just share my screen first, and then is my screen visible?
Yeah, it's very well visible.
Okay. So go to slideshow. Sorry. So at the outset, let me thanks Dr. Sudhi. It has been ages later that we and Sudhi came back again, and thank you for this. Thank you to this forum. Sudhi and myself, we were together at SGPGI, and we have sort of a common journey for thyroid. Thyroid was more done by endocrine surgeons there. At the current institute where I'm working, we also do a lot of thyroid surgery. So thyroid surgeries is distributed among various specialties nowadays. And it is all, as Sudhi was telling very correctly, that as you become more experienced, the challenges also start increasing. And that's where it was so apt today that when she talked about discussing post-thyroidectomy laryngeal nerve injuries, I also got excited. I also got to study something. There is a certain part of it which ENT surgeons, along with doing thyroid surgeries, deal is the laryngeal nerve paralysis. So, without wasting much time, let's come to the topic of post-thyroidectomy laryngeal nerve injuries, a complete guide. Just a minute. Yeah. Is my slide changing?
Yeah, it has changed.
Okay. So when we talk about laryngeal nerve paralysis, the stakes are high. For all surgeons who are doing thyroid surgeries, we are actually at the depth of our heart are scared with this complication because it profoundly affects the patient's quality of life. And surprisingly, voice change post-operatively can range from 30 to 80%, out of which 1.5 to 14% may be result of recurrent laryngeal nerve injury, that is the rate, in which 2 to 3% can lead to permanent vocal cord paralysis. So if you have the numbers, you can imagine 2 to 3% of that can be permanent vocal cord paralysis. Bilateral recurrent laryngeal nerve injury is rare. It is 0.2%, but when it happens, then is again, I would say, a nightmare. So before we delve into the details of, what happens, how the patient presents to you, what will happen in the post-operative period, and how will you go managing such cases, let me just give you a brief overview of relevant anatomy and pathophysiology of the same. So, this is our larynx. The vocal cord of that organ by which we speak is very intricately managed by various intrinsic muscles of the larynx, also the extrinsic muscles. But why intrinsic muscles are important? Because these are the one which will be controlled by our recurrent laryngeal nerve and the superior laryngeal nerve. So you have the posterior cricoarytenoid, you have the lateral cricoarytenoid, you have the thyroarytenoid, the upper border of which forms the conus elasticus and the vocalis, other name is vocalis. And then you have the interesting muscle called the interarytenoid, which has both transverse and oblique fibers. So these muscles play a very important role in two functions, three functions of the cord. One is the abduction, movement away from the midline. The other is adduction, movement towards the midline. When we phonate, our vocal cords adduct, they come together, and that's when we are able to phonate. When we breathe inside, the cords abduct, they go out from the midline, and you have air inside your system. And then when you are trying to raise your voice, you're going to modulate your voice, you won't have stretch and release of your vocal cord, which when we call about tensors. So, the vocal cord is a very, very interesting and a very delicate structure controlled by these various muscles. This is a diagram I think all of us, all of you would be very well aware of regarding the supply of vocal cord. So this is what supplies the vocal cord, the vagus nerve. Vagus nerve would divide in superior laryngeal and recurrent laryngeal branches. Superior then further divides into internal and external. External branch supplies the cricothyroid, which I was talking about, the tensioning of the cords. This is what does the tensioning of the cords, which helps you in modulating your voice, raising the pitch of your voice, singing, etc., etc. Internal branch will give you the sensation above the vocal cord. The recurrent laryngeal nerve, which is so closely associated to all thyroid surgeons because it runs in the area where the thyroid is. Right and left has a different course, and we all know that left traverses lower down in the thorax. That's why lesion in the thorax does affect recurrent laryngeal nerve very commonly. So for an ENT surgeon, when a patient comes with vocal cord paralysis, we have to rule out everything. But if he comes up with left-sided palsy, we do look at the thorax. Right, on the other hand, takes a turn. It is a recurrent, that is, it will turn higher up, and right is oblique in nature. So this is something, today I'm not going to go in the details of surgical anatomy of recurrent laryngeal nerve because I think you all are very well aware of that. And you must have had so many practical sessions and classes. And, this is what we as thyroid surgeons learn, the various triangles. So let's not go in detail of that. But yes, we have to understand that how these nerves get paralyzed. So what will happen if you have an injury at right in the brain? So that's called supranuclear and nuclear causes. You will have high vagal lesions. You have intracranial lesions, or you have skull-based lesions, or you have lesions higher up in the neck, sometimes huge thyroids, and you are operating and somehow you, you have landed up with injury to the main vagal trunk. What will happen? It will lead to high vagal lesion. What will it in turn cause? We will see that in upcoming slides. Then when you come down to the thyroid level or to the neck level or thorax level, you'll have low vagal lesions. The symptoms are a bit different. And you can have idiopathic and systemic causes for etiology of vocal cord palsies. So we have to first understand, as I told, I'll just briefly mention the pathophysiology. Why does your vocal cord behave the way it behaves in case of palsies? So there were few laws given, and few people try to understand that why the vocal cord is turning to median or paramedian position when it's paralyzed. So Simon's told that in unilateral recurrent laryngeal nerve palsy, vocal cord is in the median or the paramedian position, as you can see here, if you can see my cursor, because abductor fibers are phylogenetically newer. So that gets affected first. So abduction gets affected, the vocal cord starts to come to the midline. But a better way to explain is given by Wegener and Grossman theory, where you have the recurrent laryngeal nerve paralyzed. The vocal cord is in paramedian because of the intact cricothyroid muscle, which in turn, I was mentioning cricothyroid as a tensor. It actually is also the adductor of the vocal cord. So your cricothyroid is intact because your superior laryngeal nerve is intact. And that's why it is in the paramedian position. So when we look at the various permutation and combinations of these laryngeal nerve palsies, we'll see why this is important. And there's also an interesting theory, and very apt one, where we talk about interarytenoid muscle contraction theory, where in unilateral RLN palsies, paramedian position is also due to contraction of interarytenoid muscle, which has bilateral innervation. So I was telling you it has a transverse fiber and it has an oblique fiber. That is why one-sided would be having bilateral innervation, which will be, so if one-sided is injured, there will be function of interarytenoid intact from the opposite side. So when we look at nerve injuries in thyroid surgeries, when you can have injuries of superior laryngeal nerve, many thyroid surgeons who are learning and at early part of their career, we are all worried about RLN. We know the anatomy, we know the triangles. People start missing the SLN. But this is one thing which can get injured easily. You can injure the external branch of superior laryngeal nerve, and then patient can give you very subtle symptoms of vocal fatigue and change in voice quality. If there are professional voice users like singers or orators, they will give you very, specific symptoms that they are not able to, modulate their voice, their pitch and timbre is affected, etc. So it is a very fine sensory nerve, a very fine nerve which controls the cricothyroid and leads to these vocal problems. Then comes the recurrent laryngeal, and I think all of us know that it results in the paralysis of true vocal cord when the cord comes in paramedian or lateral position. And I was talking about high vagal lesions where you can have transaction higher up, where you can injure the vagus per se when both the nerves can stop functioning. So hoarseness in thyroid surgeries can be transient. If it is, resolving between 24 to 48 hours, is usually due to vocal cord edema by endotracheal intubation. If it is persistent or severe, it may be due to arytenoid dislocation. Again, arytenoid dislocation is one of the most common causes of intubation injury, or then secondary to nerve injury, as we all dread when we are operating. When it is secondary to arytenoid dislocation and you have recognized it intraoperatively, it's better to manage immediately. Otherwise, it's very difficult to manage at a later period. There have been reports of delayed palsies. Now, I found this very interesting, where there are not many reports of that, but just interestingly, I got this article which talks about delayed palsy in a set of 7 patients, where they thought that it was because of some edema and postoperative and everything was normal immediately post-operative. So that's also one of the presentations. So you should be, very, very sort of attentive as to what the patients are complaining of. So when I was talking about vagal nerve palsy, superior laryngeal nerve palsy, recurrent laryngeal nerve palsy, you actually, as a ENT surgeon, as a voice surgeon, you have various permutation and combination which can be possible. So as I was telling you, you are operating the upper pole, you can injure the, you're doing a hemithyroid, you can injure the superior laryngeal nerve on that side. Then you are coming down, you can injure the recurrent laryngeal nerve on that side. So you will have unilateral either SLN palsy or RLN palsy, or you can have both. Sometimes you have injured, or I'll not tell you have injured, but it can happen that you can have bilateral recurrent laryngeal nerve palsy, you can have bilateral superior laryngeal nerve palsy, and you can have very dreaded combinations of high vagal lesions on one side or bilateral high vagal lesions. So we do a lot of skull-based cases. We have certain conditions in which patients may land in very difficult condition of bilateral high vagal lesions when you have lesions in the in the jugular foramen, etc. So let me just tell you the symptoms. We might not cover that aspect of it, but we will be covering the other permutation and combination. So when we talk about these permutation and combination, why are we talking about it? Hello? Yeah. We are talking about it because they present in different manner. It is always a tug of war between voice and breathlessness. So if you have a unilateral recurrent laryngeal nerve palsy, the patient will mostly present to you with voice change. Patient, when you examine them, you will have vocal cord which is not moving properly. It is in median or paramedian position. On the other hand, if you have a bilateral recurrent laryngeal nerve palsy, what you will see? You will not have much of a voice issues with these people because the cords are already in the paramedian. They're almost approximating. And as I told you, when you are phonating, these vocal cords are in the midline. But the patient will give you complaints of breathlessness, in very severe cases, stridor. And these are, again, a emergency where most of these patients can land up in tracheostomy. Patient can come with unilateral SNN palsy, as I was telling you, very subtle complaints. Meri आवाज थक जाती है, that's what they call it. They will have vocal fatigue, they'll have subtle changes in voice, they might not be able to raise their pitch, they may or may not have mild aspiration. So we will again touch this aspect of aspiration. Sometimes patient can come to you with bilateral superior laryngeal nerve palsy, or I was talking about high vagal lesions where both RLN and SLN is gone. The sensation of laryngopharynx is gone. Aspirations are very, very pronounced. So a very interesting thing when we as ENT surgeons, when we teach our kids, MBBS students, we tell them, why was larynx made? So larynx was not made initially for phonation. It was meant to protect our lungs. So aspiration is something which, really scares us more than phonation. So I've been talking about RLN versus high vagal because again, I told you in recurrent laryngeal nerve, there'll be incomplete glottic closure during phonation with inward tilting of ipsilateral arytenoid. Aspiration is readily not visible and patient may have breathy voice. On the other hand, when both are gone in high vagal palsy, RLN and SLN, you have incomplete glottic closure, but you have pooling in saliva in the ipsilateral pyriform fossa. They have difficulty in swallowing. They have difficulty they have a lot of aspiration. Patient will have soft palate and posterior pharyngeal deviation. You have breathy voice with hypernasality, and that's where, it becomes difficult. So this is the one of our patients. This is not a thyroid patient. It's a skull base patient, a huge schwannoma. And you can see the vocal cords are not moving properly on the left side, and there's thick pooling of saliva, and he's on Riles tube. So these are the patients who may land up in a long Riles tube, and that's where today we'll be talking about speech and swallowing. These all patients, they do have good rehabilitation. If they do have good rehabilitation services, many of them come out of these conditions as well. So this patient did come out of that condition. You can have something like this, where you have presence of arytenoid edema and erythema, and absence of jostle sign. So if you have the arytenoid or cricoarytenoid joint injury, so the vocal cord, normally if it is only the vocal cord which has been denervated and your joints are okay, then there'll be a mild movement in the paramedian position. But if that is absent and there is edema around the arytenoid area, you should be careful. That might be you have injured the cricothyroid joint, or you have the joint is injured, and that's how you can recognize. It's important to recognize this, as I told, because immediately you can actually replace back those dislocated arytenoid joints. Sometimes with prolonged denervation, profound denervation, there is loss of muscular support of cartilage, and there will be sort of a prolapse of arytenoid. So these are vocal cord images of vocal cord palsies where you have denervation and you have arytenoid prolapse as well. This is something interesting case. This is one of the images which has been taken from a book where anterior approach of cervical spine has led to injury of the vocal cord. And interestingly, intact cricothyroid, which is a tensor of the vocal cord, increases the vocal cord resistance to exhaled air and better voice to the patient. So various changes and various look of these cords are possible when we are talking about vocal cord palsy. So we know, as thyroid surgeons, all of you know the importance of rectal laryngeal nerve and thyroid surgeries, how they differ, how the anatomy may differ at times, and how you should be well aware of the various triangles which a surgeon wants to see the rectal laryngeal nerve. And similarly, superior laryngeal nerve, as you become more experienced, this is one nerve which all of you, start saving more, because this is also a very common reason for voice change. So again, not going in a lot of details, but we know the superior laryngeal nerve and the rectal laryngeal nerve do carry variations. Normal trajectory on the left, that is more parallel in comparison to the right. So for a surgeon, I think might be right is more difficult. It becomes in an oblique manner. And that's what so right has an angulation of 15 to 45 degrees. And then you have various you can have multiple rootlets, you can have other things. So again, I told you, so today we are not going to talk about that in detail. People who are using IONM, there can be two types of injuries. One is the segmental injury, where there's loss of signal proximal to the injury point, and there'll be type 2 injury, which shows global injury. The nerves can be either they can undergo segmental injury due to either suture, vessel, or fibrotic band entrapping the nerve. You can have global injury due to overstretching, and actually, you could have sheared the nerve. You can have traction injury, which is, that these thyroid lobes, we actually tend to do a lot of traction to these lobes, and that is also one point. Might be your assistant should also learn that traction injuries to the can lead to injuries. It does recover intraoperatively, but sometimes can lead to permanent damage as well. Humeral injury, we all know that you should not be using these devices very close to the nerve. It is important that you should know that, and you can't keep bipolarizing and using monopolars and everything very inadvertently around this very, very sensitive nerve. So it can get affected because of traction at ligament of Berry, traction at goiter adhesion. You can have mechanical trauma during dissection. You can have constriction with subsequent release of entrapment. You can have thermal injury or transaction injury. So we all, as surgeons, want to understand that what are the strategies for RLNA preservation. So preoperatively, all of you should routinely go for a vocal cord assessment and document it. That is very, very important. And then intraoperatively, as common as Sudhi was telling, many people are now using IONM. We do also, I haven't used IONM routinely for my thyroid surgeries. I use them for facial nerve surgery, for parotid surgeries and other, also because at times there's cost factor associated with it. But today we are not discussing IONM in detail. But yes, it is one of the important tool for surgeons, thyroid surgeons. You should be a meticulous dissector, dissected properly. You can identify the nerve. It's better to identify the nerve. You should use your instruments very aptly, very suitably, go for hemostasis, and handle your tissues gently. Obviously, surgeon skill and comprehensive knowledge is very, very important. That goes without saying. So IONM, it is important that it is best used in high-risk cases for reoperative thyroid surgeries, malignancy, distorted anatomy, and anatomical variations. And it's good if you're using routinely for all your cases. And actually, that's a good practice if you can, if that is possible. So again, not going in details of that. Techniques of nerve monitoring, you have nerve stimulation. You can use intermittent stimulation or continuous stimulation. You can assess the vocal cord response to nerve stimulation, where laryngeal surface of electrode is attached into the ET tube. This is what the cost factor is. The ET tube is costly, but yes, and then you cannot use it on multiple patients. Continuous INM unfortunately can give you vagal neuropraxia. So you have to understand that aspect as well. And use of short acting muscle relaxant is important. So once we know as to what is the anatomy, how patient can present to you, how this vocal cord palsy can be prevented, and for surgeon's factor. But what if it happens? What can you do if the patient presents with this problem? So commonly, as I told, unilateral is more common. So today we'll be talking first about unilateral and then going to bilateral palsies. So interestingly, the management of vocal cord palsies is affected by three factors: etiology of nerve injury, where is the site of lesion, and what is the position of your paralyzed cord. So let's understand how it is affected by etiology. So if it is iatrogenic, you know it has been injured. As a surgeon, you know it. It warrants immediate revision and better do end-to-end anastomosis. Now there has been nerve trauma. You have recognized it later. It could be due to traction. It could be due to other reasons. You can manage it for weeks to months in conservative manner. And I could tell you that most of these lesions, you can wait for 6 months. It's usually the opposite side compensates well, and then patient's voice may come back to normal. Sometimes the movement itself starts coming back if it's just a mere traction injury, not that severe. In cases when the cord has been infiltrated in malignancy, you know that you have to sacrifice the nerve. It's better you prepare for medialization right at the beginning, medialization of the vocal cord. Now, how is the management affected by site of nerve lesion? So if it is isolated RLN palsy, as I was telling you when we were talking of the various permutation and combination, you can go for a course of speech therapy. You can wait for spontaneous neurologic recovery. And if not, if none of them is helping, you go for surgical intervention, which we will be talking about. In high vagal lesions, you know, it's important to go for vocal cord medialization with concomitant upper esophageal sphincter myotomy, which will help in speech and swallowing rehabilitation. So our challenge in high vagal lesion is not only the voice, it is the aspiration. You don't want a patient on RISE tube always. So it is a difficult thing to do, difficult thing to manage, but then that is how best you can manage them. How the management is affected by position of paralyzed cord. So if it is paramedium with a small chink, you can go for injection medialization, where you can use various particles like fat, collagen, silicone particles. If it is in cadaveric position, it has gone way away. You can do the type 1 thyroplasty. Again, I'll talk about this. If it is fully abducted, gone way behind, you also need to do arytenoid adduction, and the posterior cord also needs medialization. So coming to the vocal cord injection technique, substance, Teflon, not used anymore. You can use autologous fat. You can use gelatin sponge, which does get absorbed in 3 to 6 months. You can use bovine collagen and micronized acellular cadaveric dermis. You can use hydroxyapatite, calcium hydroxyapatite, or the Vox implant. So you have, this is again, the best thing about injection thyroplasty is that medialization can be done in OPT. You can use your flexible scope, you can mark the site, and injection can be given right in the OPD. As you have seen in these images, there's a short video which just shows that, you just have to take the needle out just below the vocal cord, turn it, you flexibly, by using flexible laryngoscope, you can see what's happening inside. And you can turn the needle on the side of the paralyzed cord and slowly inject your material and try to see how, you have to see the swelling on the side of the paralyzed cord. So slowly the injection is being given, and you can see that it has come to the midline. So what will happen now, whenever the patient is trying to speak, the vocal cords will meet in midline. So he will have a better speech. That is the fundamental principle of injection thyroplasty or injection medialization technique. But if you are not careful, what can happen? You can lead to hematoma, you can have over injection, then patient may come to you with breathlessness. You can have under injection where the voice may not be very, very good, or you can have superficial injection. Everything goes up into, not the area where you want it to be. So you have mainly these three sites where you can do the injection. And you saw in the video how the vocal cords beautifully comes in the midline and the voice becomes normal. And you can, since you are doing an OPD, you can actually immediately see your results as well. Now we were talking about conditions in which, the cord has gone much laterally, it has abducted. You can go for a technique called type 1 thyroplasty, where vocal fold medialization by means of an implant impress on the vocal fold through a cartilage window cut in the thyroid ala. This is a very interesting concept. It was given by Ishiki in Japan for cords in cadaveric position, correction for vocal cord atrophy, and even conditions for presbyphonia, where there's weakness of voice. You do not want to do it if there is poor abduction of contralateral vocal cord, and then that becomes a problem. If there is history of radiotherapy, better avoid it. So what do you do in this? You can see in this image, you want to open up a space in the thyroid cartilage so that you can push that area with using an implant so that the vocal cord, which is now in the lateral position, can come to the midline. This is, injection medialization was sort of a temporary procedure. This is something which stays. So you will do a small skin incision over the mid portion of thyroid cartilage. You'll separate the strap muscles, edges of thyroid L are exposed, and you do a location of cartilage window. So this is a very intricate step where the measurements in female and male voice boxes or thyroid L is given in a very good manner. Again, we don't have so much time to tell you all the surgical details of that, but the basic function is that you want to introduce a silastic wedge or an implant which can go through this thyroid window and push your lateralized cord. Again, a short video just to show that, these are the instruments which is marking so you can see that the window has been made and the perichondrium is being removed and the inner layer is kept intact and a silastic is being designed. This design is also specific. You can design it using silastic silicon blocks, and then you simply push it inside this window and you can use sutures, and this will push your much lateralized cord into the midline. And that is how it stays. Again, you can see this intraoperatively using a flexible scope from above, how medialized it has come. So you can use the various systems, different types of implants are available. You have the Montgomery system, you have the Vocom system, the titanium medialization implant, you have the Cortex implant, you can actually keep pushing it till your cords are in the midline. But there are certain pitfalls. If you have not done a good cartilage window, then it becomes difficult to give a good result. You can have insufficient elevation of inner perichondrium. So it's not pliable enough that the silastic is pushing the cord medially. You can have suboptimal fixation of these silastic wedges. It can get extruded and that becomes a problem. If you're not careful enough, you're not gentle enough, you can even cause fracture of lower limb of thyroid ala. You can have hematoma, edema, you can land up in stridor. So you can have local infection. It is a surgical procedure. You can also have extrusion of implants. So this is a surgical procedure. It has its own pitfall, as all surgeries have. But then again, if it is patients who have permanent voice changes and not responding to other medications, it's a good surgery. As I told, when the cords are very much lateralized, you want to also decrease the gap at the posterior commissure. So for correction of large posterior glottic gap, which is too wide to be approximated by injection, then we do arytenoid adduction. And again, arytenoid adduction is not a very, very difficult procedure. You just have to locate the muscular process of posterior cricoarytenoid. Nylon is passed through the muscular process of arytenoid, and thread is pulled under audiophonetry control. And it will actually lead, so you can see this middle diagram, how you can actually lead to, so what will happen is the posterior aspect, the posterior glottic space will come down. So that will give you better vocal result. If you're not careful enough in these surgeries, you can internally to RLN injury, you can lead to fracture of arytenoid, under or overcorrection, and again, edema and hematoma. So all these surgeries, it is a surgical procedure, have their own set of complications. So this also carries a learning curve. It's better to be, to learn these procedures before attempting them. Sometimes for voice changes, you can go for type 4 thyroplasty, where you can change the tension of these cords by lengthening or shortening the vocal cords. Again, today not going to detail, but telling you that speech quality can change by doing various types of thyroplasty surgeries. Reinnervation procedure is something which has come up in big way. It is one of the best way of treating unilateral vocal cord paralysis or bilateral vocal cord paralysis. The aim is to restore muscle tone in posterior cricoarytenoid and thyroarytenoid. Recurrent laryngeal nerve has both adductor and abductor fibers. And as we told, that abductor fibers get affected earlier as it is phylogenetically new, and it is in the periphery of the nerve trunk. That's why when we talk about that, mostly abductors are damaged, the vocal cords approximate in midline, and adduction is still possible. So, that is when we understood the pathophysiology. And there are additional contraction of other adductors like the cricothyroid. So that is why the vocal cords are in the mid position, and adductors are paralyzed and vocal cord. If there is complete, RLN is completely gone and the other adductors are also not functioning, they go into the cadaveric position that is far lateral to the midline. So reinnervation procedures have been given, and you can reinnervate using the ansa cervicalis to the recurrent laryngeal nerve. It is the most commonly used donor nerve. It is very well visible in the neck when you're dissecting the lateral aspect of neck. You can actually use 3 branches of ansa, which can be directly anastomosed to RLN, and many times that shows a good result. You can have nerve muscle pedicle to lateral thyroidnoid muscle. The ansa cervicalis nerve muscle pedicle is harvested from the omohyoid muscle and temporarily left aside on the jugular vein. And again, through a thyroplasty window, the nerve muscle pedicle is sutured to the lateral thyroidnoid muscle. This is something which I haven't done personally, but yes, people are doing that for good vocal rehabilitation of patients. So reinnervation procedures have come up big way in management of vocal cord paralysis. So that's how you manage the common paralysis of, as I said, unilateral. Now coming to the bilateral vocal cord paralysis. Again, when we talk about it, patients will present more with breathing issues, not with voice issues. So you can have various causes of bilateral injuries, and thyroid surgeries are also one of the causes of bilateral vocal cord paralysis, and others, as you can see in this chart, where it could be trauma, it could be neurological lesions, systemic diseases, etc., etc. So most of these patients, to be very frank, they land up in tracheostomy because they come to you with stridor, or in post-operative ward, they are in stridor. In ICU, they might go to in stridor. So what do we do? So the cords are in midline. And previously, we wanted to bring the cords through midline, bring the cord to the midline so that the voice could get better. But here, the vocal cords are already in the midline. So what do you want to do? Your basic function is that the patient should be out of tracheostomy. He should be out of any breathing issues, because that is very, very important. For a human being, ABC, breathing is more important than voice. So then comes the concept of vocal cord lateralization, concept of posterior cordotomy. What do you mean by posterior cordotomy? You want to make space at the posterior aspect of your larynx so that the patient can breathe. And here also re-innovation procedures have its role. So there is a special instrument called the special needle holders, where you can put in sutures inside endoscopically. You can actually take sutures and you can lateralize the vocal cord, and patients will have adequate airway to breathe. This is again a surgical procedure, and these special needle holder, the Lichtenberger endoscopic vocal fold lateralization has been mentioned, where a non-resorbable 3-O-proline suture is placed around the vocal process of arytenoid and tied on the outer surface of the thyroid cartilage, leading to the lateralization of the vocal cord. The other, which was given by Woodman, is, you create a space at the posterior commissure. You can use various instruments to do so. You can use cautery, you can use coagulations, you can use lasers. So one of the most common nowadays is endoscopic CO2 laser, which we also call the Kashima surgery or Denison-Kashima surgery, where you just do simple transaction from the vocal process of arytenoid through the vocal ligament. So this is your vocal ligament. If you can see my mouse, the false cord and ventricle is done with thyroid cartilage as an X. So you can actually go further laterally and disjoint it, and then you can actually make space very easily. I'll just show you this in a small short video, which we have done in one of our patient. So this is, we expose it, we use CO2 laser. You can actually cut that area. We are at the posterior commissure, and you want to make space here. I have not put the full surgery here, but you can see this is the transaction which we are doing, and that soft tissue at the posterior aspect we are trying to remove by using a CO2 pulse laser. So what is happening at the end? I also go further posteriorly when I'm doing it, some boggy mucosa around the arytenoid also. But now you see that there is a big area, the airway is there. So there is slight compromise between voice and breathing, but at the end of the day, we could decannulate this patient, which was a big achievement. So this was a trauma patient who had come to he was a suicidal case. He was somehow saved, and then he had bilateral recurrent laryngeal nerve palsy. We have decannulated him just now, I think last month. So it is one of the least invasive methods, endoscopic vocal cord lateralization. There is another very interesting concept, which I'll just talk about, where you can do something of this procedure, where you can do a cricoid split and rib grafting. So it is, again, for bilateral vocal cord paralysis. It preserves the integrity of bilateral cricoarytenoid joint, can avoid tracheostomy in children where anterior commissure is not damaged and there's no irreversible damage to the laryngeal tissue. So you just have to use a vocal cord retractor. You have to put incision here, and you can place a small rib cartilage there, and the vocal cord will remain in a lateralized position. That's also an interesting concept. Again, I haven't had personal experience of this, but it has been well documented in literature. Re-innervation procedure here is, the ideal nerve here is a split phrenic nerve, which restores the abductive movement and is more challenging to do. And again, this is not as easy as what we have done in unilateral re-innervation procedures. But yes, abductor muscle re-innervation procedure for bilateral vocal cord palsy is very much given in the literatures. It's still in the field of research, re-innervation of posterior cricoarytenoid, simple nerve grafting to recurrent laryngeal trunk, follows random pattern of re-innervation to both muscles, and you can have synkinetic movement of the vocal folds. So people are still, trying to upscale their management to give them good voice or give them good, give them good breath, try to manage their swallowing. So people are trying to put in better methods of management of vocal cord paralysis. Again, today I'm so lucky that I'll be able to listen to our speech pathologist, who will be talking about speech therapy in vocal cord paralysis. It's important because it improves your voice quality. It facilitates compensatory mechanisms, enhances breathing and breath support. Many times it manages swallowing as well, and prevents pathological compensation. This is also very, very important in speech therapy. And I think my next speaker is going to cover that. and it also promotes vocal cord mobilization. So it's speech therapy for vocal cord paralysis is a very, very important aspect, because anything which we do with vocal cords, even if it is a microlaryngeal surgery, we make it a point that they go through speech therapists, then they do understand the importance of voice and what they can do to improve their voice. Swallowing therapy, again, when we're talking about high vagal lesions, we're telling how challenging it becomes for us to, wean them off these rice tube. So swallowing therapy, again, as I told, we do a lot of skull-based cases, and patients do come to us with these, problem of, so it takes months. But if they are into intensive swallowing therapy, like effortful swallow, Mendelssohn's maneuver, tongue pullback, yawn exercises, they do come out of these, constant dependence on rice tube. So that these two important, very, very important aspect of vocal cord paralysis is that you should be in close touch with your speech and swallowing pathologist, and try to discuss these patients how you can better help them. So for an ENT surgeon, the dreaded step ladder is, you know, if your vocal cord paralysis gets sorted by speech and swallowing, you're so happy. You do not want to have patients with Ryle's tube and tracheostomy. You have surgical procedures like epiglotopexy. You want to, protect your larynx from constant aspiration. You have to stitch the epiglottis, or, make the epiglottis raw, and then you have to put that into the vallicula so that the larynx is protected. Sometimes our texts also say that you might have to go for total laryngectomy if he's aspirating and aspirating. So that is the dreaded step ladder. I know I would never like to land up here. So I think this is where I hope that I have just done some justice to the management of vocal cord paralysis, and I would like to listen to our next speaker so that then later we can have discussions in detail. Thank you again for letting me talk about it. I also get to learn whenever you get a chance to present such topics. Thank you, Dr. Sudhi, and I hope the whole Brendos team had had got some advantage of this talk. So thank you
Absolutely,
again.
absolutely, Bhavna. Thank you very much. That was really an elaborate and very enlightening presentation that you did. So, because speech and swallowing therapy that you just mentioned is, I think, it's one of the core management of
Yes,
any such laryngeal injuries that we have just studied. Because more than 90, I think 99% or maybe more than 99% cases are just managed with the help of speech and the swallowing therapies. More than
yes,
99%. It's only 1% or maybe less than 1% of patients they really required any surgical intervention or any reinnervation procedures. So with for this, we have a very eminent speaker. Already I have introduced Dr. Sharlene Karketa, and we are fortunate that she is with us, and they manage a lot of such patients. And today we are going to learn very basics, a practical aspect of these speech and the solotherapy. So, Shalin, should I share the screen, or would you like the presentation rights?
Ma'am, you can share from there itself, no problem.
Right. Thank you very much. So I'm now sharing. There are a lot many questions that I have received till now for Bhavna, and I hope for Shalin also we are going to have many questions. So I request all the participants to keep their questions, keep on writing their questions at the end of our program. Certainly, we'll be providing you an opportunity to discuss this with our experts. So over to you, Shalin.
Thank you, ma'am. Very good evening to all the esteemed team. And I would like to extend my thankfulness, and I am very thankful to Dr. Sudhi for giving me this opportunity to be a part of this program. Myself, Sherlyn Elkagetta. I am a speech language pathologist, and I'm in this field working since it has been more than 15 years, and I have been rehabilitating different speech and language issues along with the cochlear implant rehabilitation. And I have been in Meerut since 2011. So I'm still learning and still working, and I'm really grateful to be able to listen to Dr. Kranti today because I have heard a lot about her. And I'll just jump into my topic now.
Yes.
Basically, I'll be talking about what is the role of speech therapy post thyroidectomy. As we know that after the surgery, there may be many chances of unilateral, bilateral recurrent nerve injury or involvement of both superior and recurrent laryngeal nerve. If there is any involvement of both the recurrent and superior laryngeal nerve paralysis, both vocal fold lie in the intermediate position. And if there is only recurrent laryngeal nerve paralysis, the vocal fold will be in a paramedian position. In detail, you might all have understood, and I don't need to explain all the positions and all. But here I'll be mainly focusing upon the adduction of the vocal cords and the abduction of the vocal folds, since they are affected more. When a patient comes to the clinic, we try to gather a brief history about what was the onset and what are the challenges and the voice demands the client is facing, the presence of swallowing or aspiration complaints, and how they are being affected due to this challenge into their daily life. Oral speech mechanisms we need to assess. For example, our tongue, our palate, our oral articulators, everything we need to examine and see whether it is getting deviated to which side, and so that it will help us to understand more which side and what type of nerve is affected. No doubt, we have the brief history about the surgery also after the patient visits the doctor and they come back to us post surgery. Perceptual analysis, we sometimes use the GRAP scale, which help us to understand where the client is having a mild or moderate or very less problem. Next slide. Our aim is to improve glottal closure, reduce breathiness, enhance airway protection, improve vocal efficiency, improve pitch control and vocal fold tension, strengthen the cricothyroid function, and reduce fatigue. So we usually do the compensatory strategies. We try to teach the client how they will be able to use it so that their behavioral changes or environmental modifications will help the individual to reduce the negative consequences of deficit, increase independence, and improve participation in daily activities by working differently or achieving functional communication. Next slide. So these are some of the compensatory strategies what we use to help the client overcome their speech problems, or if they come with the swallowing issues, like vocal fold exercises, intermediate E phonation, chin tuck, which is chin down for neck flexion, pull push exercises, which I'll be explaining in further points, intermediate galvanic stimulation, that is an instrument based which we give slight current to the muscles so that they help to achieve more compensate the nerve to compensate better for functioning. Swallowing strategies is help them so that they are able to when they have the swallowing issues, they are able to take their food easily, irrespective of what type of food they are um, suggested, like solid or semi-solid, or if they are able to individually take all parts of food. Head tilt, that is towards the stronger side, so that the gravity drains bolus along the side. That means when a client is having a left side or a unilateral vocal fold palsy, the client is asked to tilt the head. Tilt the head, that is, in some kind of this type of position, so that if the right side is having a problem, so the client will be tilting the head towards the left side, the stronger side, so that when they are taking the bolus inside, they are able to swallow it easily. And in general, we try to give them the information regarding the vocal hygiene, and so that they do not learn the malpractice after the surgery. Okay, the first thing when we look upon the vocal fold, vocal paralysis cases, we ask the client to have phonation exercises. That means inhaling the air and phonation of A or E. That is the vowel phonation. So breathing, since whatever the condition is, we try to make them practice more and more breathing exercises so that they are able to, sustain a good um, air capacity for speaking or other functions. Pushing exercise, that is while having making the client stand facing towards the wall, and we ask the client to put their arms on the wall, and slowly they need to phonate ah after breathing, and they have to um, they need to go forward towards the wall while phoneting ah. This will help their vocal folds to uh, adapt, because when they are not able to bring their vocal folds together, the pushing exercise helps them to bring the vocal folds to the midline. Pulling exercise, in the other hand, we ask the client to sit on the chair, and they need to hold the seat. While sitting position, they need to hold the seat, and they need to pull themselves up against the gravity. That means they're going to pull their own weight, so that the pulling exercise also helps the vocal folds, that is to help the adduction mode to make it strong, so that slowly we work on the vocal folds muscles. Like I said, there are some instruments which I didn't use in our clinic, but there are suggestions for using intermediate galvanic stimulation, that is, like a muscle stimulator, which will help to enhance the nerve activation. Sometimes we need to give extra help or extra vibration, so that the muscles and the nerves, they work together. As I said, pulling against the chair and pushing against the wall, they help us to phonate under resistance. You will be doing this exercise while phonating any vowel A or E. There are some other instruments like EMST 150 that also helps to maximize pressure of expiratory muscle by blowing into the device until you get enough pressure to open the spring-loaded valve. As we know, like superior laryngeal nerve palsy, it reduces the pressure of expiratory muscles. So with the help of this instrument, you can help the client to achieve more pressure. Swallowing is also one of the main issues after this injury. As ma'am has mentioned, Mendelssohn maneuver, that helps us to make the pair to make understand the client that when it is difficult to swallow any food particles, how they need to take in. So when we ask them to take in the bolus, the maximum laryngeal elevation is restricted. So with this method, it is like when you have to take the food, you need to squeeze your laryngeal muscles, and then slowly, because sometimes they are very scared to swallow any kind of food, whether it may be saliva or whether it may be even water also. So we can ask them to sip a small bit of water or any liquids they are taking, or small portion of bolus. Chin tuck against resistant is also helpful for swallowing disorders. Like you need to put your chin close to your neck, and then when swallowing or phoneting, you need to put your chin against the, like your chest, and then you need to swallow. Head tilting and head rotation is also helpful many a times, where the tilting towards the stronger side, as I mentioned earlier, and head rotation towards the weaker side. So if my right side is weakened, so the head rotation towards the weakened side will help the left side or the stronger side to compensate for the weaker side. And it is usually helpful for the unilateral palsies. Head back position, again for bilateral palsy, facilitating for swallowing. You can ask the client, whenever they drink or eat, they can take their head back and slowly swallow. Uh, Sometimes we need to counsel them a lot because they're very reluctant, and sometimes they're very scared, and they avoid to even take any kind of food or liquid. High pitch E phonation also is very helpful for the vocal fold adduction, where we ask the patient after breathing, we need to pronounce E, that is A and E phonation. But for intermittent E, you need to say with a high pitch or like a falsetto. E, 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 E. This will enhance the vocal fold adduction. Next slide. So sometimes the question arises, and many a times the caretaker or the client, they ask like how much time will it take them to speak back again. So usually, as you know, the recovery period or the spontaneous recovery, it's around 3 to 6 months. And depending upon the partial and complete injury, like 6 to 12 weeks, we can work rigorously so that the patient doesn't adapt any maladaptive compensations. And unlike recovery of without surgery, it is not possible. Therapy optimizes the functions. Usually the duration guidelines, they usually guide us like for mild problem, it's 6 to 12 weeks. And if they're showing any kind of recovery or any changes, then you might have the recovery period or the window into positive side. Moderate level, it's like 3 to 6 months, and we need to wait till then because they're very impatient also. They think like how early are we going to have our voice back? And this may be a very challenge because during this stage, sometimes they drop off from the speech therapy also. And since they are not able to make out any drastic change, they sometimes they're very demotivated, and these things really affect a lot for the speech therapy to go on further. And if there is no progress about 3 to 6 months, if you see there's no progress, not much, then we can again refer back to our surgeons so that they can see again further for the any resurgery or any other medications they need to go for. So criteria for therapy modification, same as I said, 3 to 6 months. If you don't see any changes, then there is a high time that we should again refer back to and get in line with the surgeons, and so that we can plan out the further treatment in an effective way. So persistent aspiration despite compensatory swallowing strategies, it's a high time to go for surgery again. Next slide, ma'am. Thank you so much. And overall, I would like to thank every one of you for listening. And ma'am, thank you so much for the opportunity. And I'll be more than happy if I if I learn more from you all.
Yeah, thank you very much, Sharlene. And that was really very enlightening. But there are a lot of questions that I would like to clarify from you. तो अभी आपने बात किया था कंपनसेटरी स्ट्रेटजीज का, तो
जी
इतना हमें समझ में आया हम सॉल्विंग बिकॉज ये जो वंस द लेरेंजियल इंजरीज आर डन मोस्ट ऑफ द टाइम दीज आर पार्शियल इंजरीज अंटिल अनलेस की बिल्कुल ही एकदम नया सर्जन है उसने नर्व को काट दिया या कुछ, अदरवाइज यूजली डिस्ट्रैक्शन होती है, थोड़ी बहुत माइनर थर्मल इंजरीज होती हैं, या बहुत ही हाई रिस्क केसेस होते हैं, एडवांस सर्जरीज होती हैं जिसमें कि वी गेट्स, सो मोस्ट ऑफ द टाइम इट इज पार्शियल, सो देयरफॉर योर रोल इज वेरी वेरी इंपॉर्टेंट. सो माय पॉइंट इज कि अगर पेशेंट आया आपके पास, उसने कहा हमारा थायराइड सर्जरी हुआ है, उसको होर्सनेस है और खाना सटकने में उसको खांसी आ रही है ना, वो उसको लिक्विड लेने में डिफिकल्टी है, तो आपने उसको असेस किया, आपने उसकी क्या आप रूटीनली उसका वोकल कॉर्ड लेरिंजियल एग्जामिनेशन करा के चेक करते हैं कि उसको क्या इंजरी है, या फिर आप क्लिनिकल बेसिस पे टेस्ट करते हैं?
परसेप्शुअली देखते हैं मैम, और साथ में हम ओवरऑल ओपीएम मैकेनिज्म्स को भी देखते हैं। और उनको जांच करना बहुत ज़रूरी होता है, क्योंकि तभी पता चलेगा किस लेवल तक आपका इफेक्ट आया है। अगर वो बार बार अगर वो उनको धक्का लगता है, दे आर नॉट एबल टू इनटेक एनी काइंड ऑफ लिक्विड और फूड, तो एक बार में हम लोग यूजुअली सजेस्ट करते हैं कि आप एक बार ना वीडियो फ्लोरोस्कोपी या इस टाइप का ना, लाइक ईएनटी
लेरिंजियल
सर्जन को।
एग्जामिनेशन
राइट,
बताइए।
या उसके उससे बहुत क्लियर पिक्चर समझ में आता है कि अपना आपका वोकल फोल्ड कितना अफेक्टेड है, और साथ ही साथ कहीं और भी कोई और भी हिस्से हमारे जो कमजोर पड़ गए हैं, एंड दैट इज लीडिंग टू एनी काइंड ऑफ choking kind of, or they're not able to विद द एस्पिरेशन भी अगर देखते हैं, और उसके साथ साथ अगर खाने का भी अंदर लेने में दिक्कत हो रही है, तो ये सिर्फ परसुएसिवली नहीं होना चाहिए, इट शुड बी इंस्ट्रूमेंट बेस्ड एग्जामिनेशन में।
राइट। तो उसके बाद जब आपने कहा कंपनसेटरी स्ट्रेटेजीज के बारे में आपने बात की, तो मैं इसको खोल लेती हूँ एक मिनट आपका प्रेजेंटेशन।
जी।
एंड अब इसको मैं थोड़ा सा और समझना चाहूंगी, ये शायद मैं इतना अच्छा ग्रेस्प नहीं कर पाई। आपने कहा कंपनसेटरी स्ट्रेटेजीज आर न्यू टेक्निक behavioral changes in environment and that can help an individual to reduce the negative consequence of a deficit। इसको थोड़ा सा आप इलेबोरेट करके बताएंगे क्या होता है और कैसे करते हैं आप?
कंपनसेटरी स्ट्रैटेजीज वो सारे थेरेपी टेक्निक्स हैं मैम, जब हम थेरेपी में उनको बताते हैं, अपार्ट फ्रॉम हम टेक्निक को समझाते हुए उनको हम काउंसलिंग भी करते हैं, बिकॉज उनको बहुत नेगेटिवली इम्पैक्ट रहता है वो, क्योंकि पहले जो कर पाते थे वो चीज़ें नहीं कर पा रहे हैं। स्पीच एंड स्वॉलोइंग, ये चीज़ें बहुत मायने रखता है फॉर एनी इंडिविजुअल, स्पेशली फॉर कम्युनिकेशन एंड ऑल। तो एक साइकोलॉजिकली भी वो उनको काफी इफेक्ट रहता है कि ये चीजें हमसे नहीं हो पा रही है तो कब तक होगा वाली चीज है। तो कई बार ऐसा होता है कि अगर हम जल्द से जल्द नहीं स्टार्ट करें थेरेपी आफ्टर सर्जरी वगैरह, तो कई बार होता है कि वो टाइम ड्यूरेशन और हाउ फ्रीक्वेंट दे आर विद देयर प्रैक्टिसिंग either एट होम और फॉर कमिंग फॉर स्पीच थेरेपी। तो जो स्ट्रैटेजीज उनको सिखाया जा रहा है, वो ओवरऑल फंक्शन ऑफ देयर डेली लाइफ में, जो खासकर कम्युनिकेशन में उनको हेल्प कर सकता है, क्या क्या चीजें कैसे करना पड़ेगा, वो सब सिखाया जाता है, ताकि मेन मकसद ये रहता है कि आपका बोली को उसको सपोर्ट मिले, और वो सपोर्ट मिलते हुए तब जाकर के आप उधर कम्युनिकेट कर पाओगे।
राइट। तो मतलब कुछ आप उसकी लाइफस्टाइल में मॉडिफिकेशन करते हैं, थोड़ा सा एग्जाम्पल के साथ बताएंगे इससे, जैसे कि?
फॉर एग्जाम्पल मैम, जैसे जैसे मान लीजिए, सिर्फ थायराइडक्टोमी की भी नहीं बात करूंगी मैं, एक छोटा एग्जांपल लेंगे। यूजुअली कई बार होता है कि अकॉर्डिंग टू डिफरेंट प्रोफेशंस ऑल्सो, है ना, जैसे कोई टीचर्स है या कुछ क्लाइंट्स जो जहाँ पे जिनको वोकल नोड्यूल हो जाता है ना, वोकल फोल्ड में नोड्यूल होता है, या किसी प्रकार से वोकल कॉर्ड पैरालिसिस वगैरह हो जाते हैं। तो नॉर्मल सिम्टम्स ऐसा लगता है कि मुझे गले में कुछ अजीब लग रहा है, या मैं ठीक से बात नहीं कर पाई, या मेरे होर्सनेस आ गया है, पता नहीं हवा सी आ रही थी। ये सब चीजें मैं कैसे ये कैसे हुई नहीं पता। समटाइम्स उनको टाइम भी लग जाता है समझने तक कि हाँ ये कोई ऐसी दिक्कत है तो हमें डॉक्टर के पास जाना चाहिए, वो टाइम भी हो जाता है। तो जब वो डॉक्टर के पास मिल के आते हैं, दे हैव देयर आपका जो एंडोस्कोपी और वो सब चीजें हमारी हो जाते हैं, हमारे पास रिपोर्ट्स रहते हैं। सो व्हेन दे आर सजेस्टेड कि अकॉर्डिंग जितना सिवियरिटी रहा है उसके लिए या तो सर्जरी हो, या फिर जैसे नोड्यूल वगैरह के लिए यूजुअली जल्दी से नहीं करते हैं, टू द एक्सटेंट अगर बहुत ज्यादा गहरा ना हो नोड्यूल, सो अनटिल एंड अनलेस इट्स रिमूव बिफोर दैट दे लास्ट की जाओ थेरेपी आप कराओ। सो व्हेन दे कम वी नीड टू मेक देम अंडरस्टैंड कि ये कंडीशन बना है, और आपको ये चीजें ये पर्टिकुलर एक्सरसाइजेस करनी है। तो हम साथ में थेरेपी के दौरान उनको सिखाते हैं कि लाइक व्हाट आर द पर्टिकुलर एक्सरसाइजेस यू नीड टू फॉलो। वोकल हाइजीन है, कहाँ आपको अपने वॉइस का मिसयूज या फिर किस तरह से ध्यान रखना है, वो सब चीजें उनको बताया जाता है। और फिर डिपेंडिंग ऑन द डिफरेंट केसेस, तो वो टेक्निक्स को हम यूज करके उनको एक टाइप से कंपनसेट करने के, जहां उनको प्रॉब्लम हो रही है वहां पे वो टेक्निक्स यूज करके हेल्प मिले, वो हम सिखाते हैं, ताकि उनको धीरे से उनको ना कम्युनिकेट करने में, है ना, उन सब चीज़ों में हेल्प मिलता है।
Can I add something in this?
Yeah. So I suggest कि we restrict ourselves to post thyroidectomy cases, कि post thyroidectomy में हम क्या टेक्निक्स यूज करते हैं अगर कुछ भी है, बिकॉज लाइक दिस प्रोग्राम इज रिलेटेड टू पोस्ट थायराइडेक्टमी।
या
इसमें ये अभी अभी डॉक्टर भावना अभी कुछ अपने इनपुट्स देना चाह रहे हैं, हम उनकी सुनेंगे। डॉक्टर पूनम इज विद अस, मैं उनसे भी और अगर हमारे फैकल्टीज हैं मैं उनसे भी इनपुट्स लूंगी। बट उसके बाद लाइक शर्लिन, मैं जानना चाहूंगी आप मुझे अगर सिस्टमैटिक वे में बताएं कि आप कौन कौन से फोनिक्स लेते हैं, उनको क्या ड्यूरेशन बताते हैं कि दिन में कितनी बार करना, 5-5 मिनट, जस्ट फॉर आर अंडरस्टैंडिंग। सपोज ए पेशेंट आपसे कंसल्ट करके आए और उसे समझ नहीं आया, वो हमसे पूछे तो हमें भी पता हो इन सब चीजों के बारे में। और उसके बाद जो आपने बहुत सारे मैन्यूवर्स बताए थे चिन को लेके, वो क्योंकि उस वक्त आपका स्क्रीन शेयर हो रहा था तो उस वक्त आपने दिखाए भी होंगे तो हमें समझ नहीं आया। वो हम सारे मैन्यूवर्स मतलब 1 to 1 आप स्ट्रेटेजिक वे में हमें दिखाएंगे तो अब हमारी ऑडियंस को बहुत अच्छे से समझ में आएगा। सो ओवर टू यू भावना, यू वर सेइंग समथिंग।
So, uh, as Shalin was telling, speech therapy, why it becomes important, as you were telling also, that primarily when you have these kind of paresis, usually it comes back. And it is there that you have to go for these various exercises, which we actually now believe our speech therapist will. But along with that, as a surgeon, also, you have to tell them that why because most of the places might not have good speech therapists. At times, you have to tell them that, look, they become very scared that what has happened to their voice. So just to maintain their voice, how you have to tell them they do not have to whisper, you don't have to, you don't have to over stress. So the therapist tells them that this is a treatment for you. It is a treatment for you, and that's what a ENT surgeon should also tell. We cannot treat that on that. The speech therapist will be the person who will be the ideal person to tell what are the various exercises, which I think she has covered more of swallowing, and speech similarly has to be done as a proper exercise module. And most of these patients, as you know, the cutoff for us is also 6 months. And many of these patients come back with, they come to normal at times, normal with some mild changes, which is good enough for a normal lifestyle. So that is a very, very important aspect for a thyroid surgeon to understand. Don't panic at times. Sometimes it's just a transit injury, which I was talking about. Most commonly, that is the injury, which does come back. But
Yes.
6 months is something which I would like to say.
Yeah. Yeah, most of the recovery happens in the initial three
Yes.
months.
3 months,
अगर
yes,
होनी
3
होती है तो
months.
3 महीने में हो जाती है, अगर तभी भी नहीं हुई तो
Yes.
चांसेस बहुत लो है कि वो हो।
बहुत low हो जाता है, exactly. So 3 months is something which we all should say. Surgical intervention, you can actually plan between 3 to 6 months, but I would say that 6 months is one thing which you can wait, rare
Yeah.
cases.
Before I go into Sherlyn, मैं थोड़ा सा समझना चाहूंगी। पूनम is with us. I hope Poonam, if you are comfortable, because she is in transit towards Ahmedabad,
Okay.
she is comfortable, she can join. She can give her input. Are you there, Poonam?
Yeah, I'm there, Sudhi. Actually, I have come for another conference, but yeah, I can add up on that. So, what was the question, Sudhi? I was listening to. First of all, I would like to congratulate Dr. Kranti. It was actually a very good lecture, very
Thank you, ma'am.
comprehensive. Yeah, it was a great lecture. I think
No, I
bonding
love your
is one
lectures.
of the
I
important
keep
aspects.
watching all of them. I keep
Oh,
watching your
thank you.
lectures on YouTube.
So
Lot
now
of
I have to do
information.
the now I have to do the same.
No, thank you.
So, Sudhi, what was the question? Sorry, I missed the.
Actually,
I was listening to.
actually, we were just discussing about कि जैसे your experience you can share with we just discussed about कि ये जो हमारी पोस्ट थायरोइडेक्टमी लैरिंजियल, उसमें हम अभी एक्सरसाइजेस के बारे में डिस्कस कर रहे थे, एंड आई जस्ट आस्क्ड शर्लिन की वो हमें एक बार डिमॉन्स्ट्रेट करके बताएं एग्जैक्टली कि वो किस तरह से स्पीच थेरेपी कैसे हेल्प करते हैं, क्या इंस्ट्रक्शन, जैसे मान के चलिए कि हम पेशेंट है, आप हमें एक बार इंस्ट्रक्ट करके सब बताइए और स्वेलिंग को भी एक बार डिमॉन्स्ट्रेट करके बताइए, ताकि हमारे दिमाग में भी पिक्चर बने कि एग्जैक्टली होता कैसे है।
Acha. Okay. So, Sudhi, what I would like to say here is that I saw the topic. मतलब काफी सारा अच्छा presentation था. It was a really nice presentation. What I felt was one thing I was thinking was that we can also discuss, if not this time, because I think it's already been a lot of discussion, that how do we prevent the this. I think we had the discussion on this, the perioperative steps, that how can the injury to the nerve be prevented. So that in itself can be a topic which I was thinking, especially for students and people who are doing it, even with your vast experience. I was thinking that some discussion could have been there. Other thing I would like to add is that usually the consensus is around 6 months, which you and Dr. Kranti rightly said, is usually you have to wait at least for 6 months before planning for any sort of intervention. And there are some studies which even suggest for up to 9 months there can be recovery. But as we all know that if we wait for too long, then there is going to be naturally the disuse atrophy of the muscles also.
Yes.
So that in itself becomes a problem. So we have to have a place where we should wait for the nerve to recover. And we can wait for that, and where we have to have that permanent injury to the muscle should be avoided. So usually the 6 month usually is considered the cutoff period for that. The third thing usually I didn't understand. Sorry, Sudhi. Again, the question that Shelin, the various. I think it's quite a complicated procedure. What the speech and swallowing people do is actually commendable, and there are actually a lot of exercises, and I think they have to be done very frequently. And I would say that the patient has to be in contact with a speech and swallowing specialist specifically for this, which Dr. Kranti had specifically, I think, had said about it. So is there any other question, Sudhi?
No,
I didn't.
I think if possible, it would be very interesting to if Sharlin can demonstrate all those exercises to us. So suppose I am a patient and I am having a speech as well as swallowing problem.
Yeah,
And
that is
now
a
you
good
tell
idea.
me
But only thing,
how will you tackle me?
the only thing I would say is that it is, even though she will demonstrate to us, we'll forget next time. So that's why I'm saying that's because there are so many
Many
these,
exercises.
many exercises and minor things which have to be repeated several times. And being like surgeons or clinicians, it's difficult to remember so many of them. So I think we can do that. But the only thing I think we'll all forget. That's the point.
Yeah, it's okay. But the thing is, ki we learned 1,000 things. We remember only 10 things. It is a natural
So,
process.
so
But
what we are
important,
doing,
unless we learn
yeah.
1,000 things,
So,
we will not remember
so
even 10 things. So
no,
it is
I understand that. That's a very important point. Sudhi, what we are doing at our center at Tata Hospital is that we have an app. If you want, I can share that app with you all. That app, it has a QR code, and this app actually is meant for this purpose only. So what we realized at our center, I'm also part of it, and this interesting part is this app has been developed by a patient himself, who is a head and neck cancer survivor. His name is Gagan Deepak. So he has developed an app basically for patients. It is in process, and we are integrating it into our system, and it will be available even on your Google Play store, and you can use it, and there you will have all sorts of exercises, even these speech and swallowing exercises. Because what I realized, your question is very valid, is that when we like these are quite lot of exercises, and these have to be done regularly by patients, but they're so complicated many a times, unless there is a speech swallowing specialist over there, they will forget. So that's why we have done few videos for that, and they will be available, and we can even include Kranti into the Cheryl into that. I'm sorry if this pronunciation is not right.
Shalin, ma'am.
So I'm sorry. So Shelin can also be can give us inputs. So that is also a good way to, you all can share with patients, and it can be used there. That's my
Great.
just point on that.
That's a great idea, and thank you very much, Poonam. And we would love to have that app at least for the patient that are nearby us. So,
And it has all other exercises also, like physiotherapy, how to give
Physiotherapy.
all sorts of other things. So I can share it with you later on.
So this is how Brandos contribute, where we have a lot of interaction among the specialists, and we come out with some new ideas and informations. And thank you very much, Poonam, for your inputs. And those are really very valid and very useful for us. So may I request, like Shanli, if you would
So
like to share,
Yes,
you
ma'am.
know, I just really want to
is it
understand
okay?
the five
Sudhi, sorry.
vowels and the EIU, huh?
Sudhi, I'm
Dr.
sorry. Can I leave now as I have some other
Sudhi,
commitment?
Thank you very much, Poonam, for joining. You have आप आए हो ये हमारे लिए बहुत बड़ी बात है. Thank you.
We all are friends only. Thank you so much, Sudhi. And
Thank you, Dr. Poonam. Thank you.
thank you,
Thank
Dr.
you, ma'am.
Kranti.
Thank
Great
you.
lecture. Really enjoyed it.
Thank you so much. Thank you. Thank you for your inputs.
Can you hear me?
Yes, Sherlyn. हाँ.
Can you hear me?
Yes, ma'am.
This is someone is.
Before
This is
I am Dr. Prakash Munka.
नहीं
Sudhi.
Hello.
He's a ENT surgeon from Bihar. He's in Jharkhand, in Bokaro.
Yeah. Before she demonstrate all the different maneuver,
Yes, sir.
I have few which, if you find it's useful. Dr. Kranti, first of all, it was an excellent presentation. You
Thank you,
covered
sir.
most of the different findings. The question one, suppose if you find articulation defect and there is a fracture or dislocation of the bone, should you wait for the speech therapy or you should straight away go for treat surgically? Number one.
So,
Number two, yeah, you can reply, no problem.
so I think, as I was mentioning, if you know that intraoperatively the fracture is there, it's better treat it early. Because then,
Right.
after fixity, it's very difficult to give. Even with speech therapy, it will be suboptimal result.
And probably you miss the golden time, the time
Yes,
period
yes.
the speech therapy. Secondly,
True.
like there are many conditions. What our speech therapist did explained very nicely about the different exercises. As your moderator has said, it is very difficult for the patient and the doctors to remember. So probably it is not all the exercises to be all the maneuvers to be done by all. Depending on the conditions, one person has to practice few maneuvers repeatedly. That is, I think she should be very precise in saying if condition A, this is the therapy, condition B, this is the therapy. And first and foremost, as a surgeon, if we notice a defect which is not only functional in origin, like fracture, dislocation, we should try to do it immediately. Your comment, Dr. Kranti and other panels.
Sir, number one comment, since we are talking of thyroid surgery in this particular panel, most of these injuries, as we talked about, is
I am
transient and it
talking
comes
about
back.
post-thyroid. Yeah, post-thyroid complications. You have enumerated different conditions. So depending on the conditions, which are the one which should be tackled as at the first available opportunity, and once the wound is healed, or say maybe 1 week, 10 days, what is your protocol for such therapy? Secondly, the therapy which you give all will not require all the maneuvers for a particular condition. It will be dispensed according to his or her defect.
Yes, true. So, there I did mention different permutation combination in which obviously if you know that the nerve is infiltrated, you have to cut it. You actually do your medialization, and this holds true with any of these lesions, even for skull-based lesions. You know that wiggle is going to go. It's better to do that immediately. If your joint has dislocated during intubation injury, it's better to intervene. But if it is because of, and then, as Dr. Sudhi was telling, if there's a young surgeon, novice surgeon, he has actually transacted and iatrogenic, you know that you have done it, better you go for immediate reinnervation, immediate end-to-end anastomosis. But most of the time, this is due to traction injury, due to some thermal injury, due to some edema. In post-operative, after a while, you come to know about it. It's better to wait for recovery, and then you then add these patients once you are when you are the patient is stable enough to go for speech therapy. It's better you go for speech therapy. For swallowing, most of these patients for RLN might not have very big swallowing issue. As I was telling you, different combinations where your superior laryngeal nerve, you have microaspirations, there your swallowing also is get affected. And that's when you want to have that window period of 3 to 6 months where you want to try the speech and swallowing rehab, which Sherlyn is perhaps going to tell us today. So immediate intervention when you have transacted the nerve, you have in malignancy, it has been infiltrated, you have transacted, you have removed that. And then if you have joint dislocation, not because of the surgery, but because of trauma, and then perhaps, yes, immediate. But all other aspect, I think you can wait conservative. And most of the time, patients do come back.
So the waiting time is on an consensus is about 6 months.
Yes, sir. That goes for surgical intervention. Any kind of surgical,
Right.
at least at our center, it's 6 months for now.
Before the thyroid surgery you try, you should give some window period of about 6 months.
Yeah, and meanwhile, continue your speech and swallowing rehab exercises, and they do respond to that. Many of
Yeah,
them do.
excellent presentation. Thank you.
Actually,
Thank you, sir.
within 6 months, the whole of the local area induration, swelling, it's
Everything comes down.
everything comes down, and we know how much recovery is already done. So the remaining, the deficit that we have to cover after that.
Yes,
So
True.
this
that will be a
in
better
6 months.
statement.
Great.
Thank
So
you.
actually, there are so many thyroid surgeons with us today who don't have an access to a very good speech therapist. And for earlier symptoms, they definitely by the time, even if they ask them to meet some speech therapist, they also tell some exercises from their side कि okay, by the time आप मिलने जा रहे हो, आप कम से कम ये चीजें कर सकते हो जो उनको जरूरत है, जैसे swelling में क्या कर सकते हैं. तो इसके लिए Sherlyn, may I request if you can demonstrate those exercises, some important ones which you feel
Sure,
are
ma'am.
important for to as a surgeon we must know.
Yes,
Yeah.
ma'am. I will just practically, add up. When we start a speech therapy for any clients, we'll usually ask them what will be the frequency for you to come for the therapy. So we ask them that
Yes.
twice a week आप आओ. ये बहुत जरूरी होता है. The more frequent you are with your techniques and workup, then only the results you will achieve what you are expecting. सो हम उनको प्लान आउट करते हैं कि थ्राइस अ वीक एटलीस्ट आप आओगे until and unless you face any kind of difficulty coming like thrice a week, और एक आध बार आप 2 बार आते हो. सो हर 3 दिन आप हफ्ते में आते हैं, एंड बाकी दिन like this exercises should be maintained every day. They should practice every day so that they are into the line of the rehabilitation. So जहां हम लोग बात कर रहे हैं वोकल फोल्ड पैरालिसिस का, तो ये पुश पुल जो एक्सरसाइज है बहुत हेल्पफुल रहता है. सो अगेंस्ट द वॉल एंड विद द हेल्प ऑफ द वॉल एंड द चेयर, आई विल शो यू हाउ आई यूजुअली मेक द क्लाइंट प्रैक्टिस. अज्यूम करिए कि सामने वॉल है और आप सामने खड़े होते हो. इससे पहले ब्रीदिंग एक्सरसाइज बहुत जरूरी है, बिकॉज वी नीड टू सी द एस्पिरेशन हाउ स्ट्रॉन्ग द क्लाइंट इज हैविंग. तो हम इनहेल थ्रू नोज एंड एक्सहेल थ्रू माउथ वो करते हैं. आराम से. इट शुड बी वेरी अब्रप्ट और वेरी लाइक इन अ स्पीडी वे. आप उनको हम समझाते हैं कि आप आराम से सांस लेंगे और आराम से छोड़ेंगे. दैट मे बी लाइक 15 to 20 साइकिल्स काइंड ऑफ, है ना, इन एंड आउट उसका करते हैं. सो दिस विल बी द फर्स्ट एक्सरसाइज व्हाट दे आर गोइंग टू प्रैक्टिस. सेकंड विल बी लाइक दे नीड टू स्टैंड facing the wall and with your hands right up in the shoulder length. सो आप वॉल के पास खड़े हो और स्लोली आप फोनेट करोगे हमारा एक वोवल आ या ई. सांस लेने के बाद आ. हम जितने क्लोज जा सकते हैं वॉल के, हम उतने पास जाते हैं. So this will be your pushing exercise. So this you will be like practicing it for until and unless that client feels very tiresome or fatigued. We'll ask them to start with 3 to 5 times at one time. Like अगर हम बोल रहे हैं कि दिन में आप 3 बार प्रैक्टिस करिए, शुरुआत में आप सुबह दोपहर शाम इस टाइप से आप प्लान आउट करते हो. So 3 to 5 times in the morning, 3 to 5 times in the afternoon, and in the evening also you can do. So gradually we'll try to increase the frequency and the number of trials what you're going to practice for each exercise. So this will be your pushing exercise. Coming back to pulling exercise, we'll be making the client sit on the chair, and I'll just turn the camera this way. आप जैसे चेयर पे बैठे हो और बैठने के बाद अगर आपका सीट पे आप जब बैठे हुए हो, एज यू आर सिटिंग, यू गोइंग टू होल्ड द द सीट अंडर यू. So you're going to hold the seat, and slowly after inhaling, you're going to phonate again. And during this time, you're going to pull yourself upside. So your knees and thighs, they'll be experiencing more tension, or more pressure over there. So this is the way where you're going to pull yourself sitting on a chair. Basically, you're going to carry your weight. So your weight is going towards the gravity and you're working against the gravity by pulling yourself. So during this time, your vocal folds will be coming into adduction position. So this will be helping you a lot for the adduction exercises, right? So ये बहुत ज़्यादा effective रहता है and काफ़ी helpful रहता है. So breathing and phonation with head tilting or the head rotation also helps a lot. तो आप simple है, सांस लेंगे. The breath support also you are going to understand कितनी देर तक आप maintain कर पा रहे हो. So if there is a gap, air is leaked out, so you're not able to maintain the glottal pressure there or there. तो ये सब चीजों को समझने में आसान होता है and this is going to help the client more. So breathing, phonation and the push pull exercise along with and then धीरे से अगर हमें एक दो और टेक्निक हमें ऐड करना हो तो उस हिसाब से हम ऐड करते हैं. तो हफ्ते में 3 दिन आप सुबह सुबह दोपहर शाम प्रैक्टिस करते हो. हर तीसरे दिन हम आते हैं. कई बार ऐसा होता है द क्लाइंट दे डू सिंपल मिस्टेक्स. देखने में भी बहुत सिंपल लगता है एक्सरसाइजेस पर कहीं ना कहीं वो गलतियां होती रहती है कि हम प्रॉपर पोजीशन हम नहीं होल्ड कर पाए हैं एंड फॉर हाउ लॉन्ग आई एम प्रैक्टिसिंग और इज इज द करेक्ट वे टू डू. तो वो सब चीजें जब आप फिजिकली प्रेजेंट होते हो तो दैट मेक्स अस करेक्ट और मेक अस अंडरस्टैंड कि आप सही से कर रहे हो घर पे. तो इसलिए थेरेपी पे जाना रेगुलरली एंड सो दैट यू लर्न द करेक्ट वे दैट विल हेल्प एंड लाइक ब्रिंग मोर या आपका रिजल्ट बहुत जल्दी आएगा. फिर इस हिसाब से होता है.
And what about the swallowing exercises? Some of the swallowing exercises would you like to demonstrate those? एक आपने कहा कि normal side ऐसे करके इस तरह से.
जी. अगर यूनिलैटरल पैरालिसिस है मैम, अगर मेरा लेफ्ट हैंड साइड लाइक लेफ्ट वोकल फोल्ड पैरालिसिस है तो हम टिल्ट कर रहे हैं आपके राइट साइड में, है ना. तो अगर टिल्टिंग कर रहे हैं तो हम कर रहे हैं आपका सॉरी द स्ट्रॉन्गर साइड, है ना. लेफ्ट साइड दिक्कत है तो राइट साइड है हम. और ताकि जब हम खाना खा रहे हैं या फिर हम कुछ पी रहे हैं तो वो छोटे पोर्शंस में होंगे एंड वो आपको आपका जो स्ट्रॉन्गर साइड है वो उसको इजीली अंदर लेने में मदद करेगा. So when you are taking in, then you can take in this way. You can ask the client to eat or drink in this way with a small portion and then slowly swallow. क्योंकि वो एलिवेशन वगैरह नहीं हो पाता मैम. कई बार हमारा टंग और हमने देखा कि पैलेट भी एग्जैक्टली अभी इस टॉपिक के क्लोज में नहीं, तो थोड़ा सा हटके भी मैं बता रही हूँ. जब सॉल्विंग जब होता है इशू बहुत ज्यादा भी दिक्कत होती है तो ये टेक्निक्स काफी हेल्प करते हैं. टिल्टिंग एंड रोटेशन में भी आपको काफी हेल्पफुल होता है. सेम जैसा आपने देखा जिस तरह से खाने पीने के लिए भी अगर हमारा वीकर साइड है, एक में हमें स्ट्रॉन्गर साइड में रहना है, एक हमें वीकर साइड में रहना है ना, टिल्टिंग एंड रोटेशन वाले में. तो उसमें बेसिकली ये करना है कि आपका जो स्ट्रॉन्गर साइड है वो उसका वीकर साइड का लाइक उसका भार अपने ऊपर ले लेता है. तो दैट इज गोइंग टू कंपनसेट द वीकर साइड, है ना. ये टेक्निक्स है जो उनको हेल्प करेंगे. दूसरी बात है अगर आसानी से जल्दी सॉल्व नहीं कर पाते तो कई बार हम लोग बोलते हैं कि आप पीछे करके धीरे से आप सॉल्व करो. इट्स व्हेन यू आर इन दिस पोजीशन तो आप नहीं कर पा रहे तो स्लोली यू कैन हेल्प टिल द हेड अप करके एंड देन स्लोली यू कैन स्वॉलो. तो हमें देखना होता है कौन सा टेक्निक कब उनको हेल्पफुल हो रहा है. तो कई बार होता है वेरी भी करता है तो सो वी ट्राई टू चेंज ऑल्सो द टेक्निक ऑल्सो अकॉर्डिंग टू द सिचुएशन. लास्टली आई विल ऑल्सो से दैट कई बार होता है डिजिटल मैनिपुलेशंस भी करना होता है मैम. देर आर लाइक तो एक्सटर्नली हमें हेल्प करना पड़ता है किस तरह से आप उसको लिफ्ट करना है, कहाँ कितना प्रेशर देना है ताकि आप उनको थोड़ा सा हर टेक्निक को कैरी आउट कर सको. तो देख करके हमें करना पड़ता है. एंड जी मैम.
Great. So thank you very much. And I think this was very important information. कि by the time patient is making its mind to consult a speech therapist, at least by the time they can start with some very few exercises. At least उसको खाना पीना रहेगा, dehydration नहीं होगा उसको at least. तो पेशेंट किसी तरह की फर्दर कॉम्प्लिकेशन में नहीं जाएगा. राइट. पूछने को तो बहुत सारे क्वेश्चंस हैं तो लेकिन टाइम हमारा अलाउ नहीं कर रहा है. लेकिन बहुत ही क्विकली अगर हमारी ऑडियंस में से एनीवन वांट्स टू आस्क एनीथिंग, वांट टू ऐड ऑन टू एनीथिंग, आवर एक्सपर्ट्स आर देयर. So may I request Dr. Sunil is with us, and I could see very हमारे बहुत सारे पुराने पार्टिसिपेंट्स भी हैं जो काफी टाइम से हमारे साथ जुड़े हुए। सो मैं बस बहुत ही क्विकली पूछ रही हूँ, अगर किसी पूछना है तो वो अपना
Good
माइक।
evening, Dr.
Good
Sudhi.
evening, sir. Good evening, sir. How are you, sir? So would
I'm
like
very
to
fine.
Senthil, sir. He's a very senior endocrine surgeon, great thyroid
Hello,
surgeon.
sir.
Thank you, sir, for
Hello, sir.
joining us today.
Yeah. See, it was a nice lecture and discussion. See, since it is limited to post-thyroidectomy, one is stroboscopy. See, Kranti did a good lecture, but what we do
I
in
missed.
this part of the, nation is that we form a laryngology group. See, there also you should form a laryngology group with the endocrine surgeon and ENT surgeon, because what we do, not only our post-thyroidectomies, other people's post-thyroidectomies, they refer to endocrine surgeon, because we are seniors. They'll be referring, because people get stuck up, surgeons get stuck up, and over a period of time the patients, psychologically they are down, how much ever you give reassurance. So we need a baseline stroboscopy. I hope
Yes,
Dr.
true.
Kanti will be.
True, sir. True.
Yes.
One
Then
thing which I
after
missed
that,
was these stroboscope findings of all
yes,
these lesions. Yeah.
yes. See, that is one part. Then comes the injection of, we inject fat,
Yes.
that will give a temporary relief. Then
Yes.
now we are having 18,000 rupees hyaluronidase vials.
Yes.
So if we have a stroboscopy in place, then we can inject hyaluronidase, and that also gives relief. Most of the time, the surgery cell, what we place, after surgery, that will form a clot and sit on the nerve. So that, goes away after a period. So we need not do anything. If there is a gross tracheal shift, that will be stretching the nerve. So that nerve stretch will take a long time, provided the tracheolaryngeal alignment is in place. So we have to do a 3D printing of the tracheolaryngeal apparatus. This we do in, anticipated difficult intubation, or in a big, massive thyroids, or whenever we encounter, then we do a 3D printing. That helps us a lot. Then, some people have this habit of taking a bite on the trachea without realizing, the trachea is strong because of the endotracheal tube. See, that is a very dreaded one. That stitch will be very hazardous, post-operatively. That will be leading to malfunctioning of the cricothyroid and, the laryngeal alignment. So these are a few points I thought I will just share with you all. It was a wonderful discussion. I was enjoying it. Thank you so much.
Thank you very much, sir.
Thank you so much, sir.
One last quick comment about this roboscopy. Sir has put in a very valid point. I have heard about it, but I don't have any exposure. Would you like to, Kranti? Would you like to tell कि क्या होती है और उसमें hyaluronidases
So,
का?
no, hyaluronidase is what sir was telling is one of the material to inject the cord. Stroboscopy is an investigation modality. So as I showed you many of these flexible laryngoscopy images, similarly what happens is the concept is कि हमारा vocal cord एक frequency में move करता है. So if you understand कि हमारी tubelight when a fan जब move कर रहा होता है and tubelight flicker कर रहा होता है, you will see that fan के otherwise you cannot see fan blades. लेकिन अगर ट्यूबलाइट फ्लिकर करने लगे you can see those static moments जिसमें fan static रहता है. So stroboscope works on the similar principle. हमारा vocal cord move कर रहा है, उसी resonance में वो light दी जाती है, so that the vocal cord movement becomes beautiful. You can see everything in slow motion. And अगर हम उसका detail समझें तो we have to understand that the vocal cord in itself has many layers. So you have the superficial lamina propria, you have the intermediate, you have the deep layer, and then comes the muscle. So ये सारा जो mucosal waves होता है, वो आप बहुत सुंदर से stroboscope में in a slow motion you can see. And then this is attached to softwares where you can have glottograms, you can have these graphs which can tell you. So early lesions of the vocal cord, paralysis of the vocal cord. All this have different findings on stroboscope, and stroboscope gives you excellent diagnosis. And then also when you're doing injection laryngoplasty, you can see how well, these waves have come back, the mobility has so stroboscope is indeed a very good modality for all the laryngology. Laryngology in itself a huge branch, is a big branch in ENT, which deals with different kind of laryngeal lesions. So it's a very good modality of investigation of choice.
Thank you very much. Now my picture is clear. And वही जैसे मैंने कहा कि we have a lot of questions to ask, but our time is not allowing. And I already told कि I was really very excited about today's session, and this session was really a hit. And thank you very much. All thanks to Dr. Bhavna Kranti and
Thank
Dr.
you so much.
Shalim. And because of their efforts, we were able to make it. This was really a very important clinical problem. We are getting requests from so many thyroid surgeons, and I hope, and we had a very good attendance also throughout. We had a very good attendance, and uh, to boast, like, we don't offer anything, we don't have anything fancy food or nothing else. All those who joined us, it's just they crave for learning, and they crave for clinical upskilling. And just at the weekend they spend their time, and it's really a very great like achievement for us. And with this, I would like to thank you, Bhavna, and
Thank you so
Dr.
much.
Sharlin. I would like to thank Poonam. She has just left. She was in her transit to Ahmedabad. Thank you very much, Senthil sir, for joining us. Sunil, thank you very much for joining. Sabha has left because of some other commitments, and I think we missed his inputs. And but his mere presence was always very
Sure.
positive, always very positive for us. And with this, I would like to say thanks to all my participants also. Without them, this program would not have been that success. और इसी के साथ मैं आप सबसे रिक्वेस्ट करूंगी, नाउ वी कैन लीव द मीटिंग विद द प्रॉमिस दैट next month, though it is a festival month, we will try our best to put on a meeting. Next month is a even month, so we will be having a breast meet. Those who practice breast surgeries, I request they keep themselves ready, because we are going to discuss about the very basics, the clinical interpretation of MR mammographies. एंड विद द हेल्प ऑफ एक्सपर्ट वी वुड लाइक टू अंडरस्टैंड कि अगर एमआर मेमोग्राफी हमारे पास आती है तो हम उसे कैसे रीड कर सकते हैं, ताकि वी आर मोर literate about reading MR mammographies in our next program. And this program is recorded. We don't let any intellectual inputs to get waste. हमारे सारे program recorded होते हैं. This program will also be uploaded on YouTube. For any reason anyone has missed any part of the program, they can revisit and understand कि इस तरह की situations में हमें करना क्या होता है. So with this, I would like to thank you all. A very good night. And just a last minute, if you would like to say anything, any few words for our team, they would be glad to listen from you.
No, just to end this, Sudhi, this is such a good, way to teach and learn, excellent effort, and actually something which we would like to emulate at our center. And, thank you for letting, me also, because I also I'm not purely into laryngology. We do have, we do all our, as I told, we do a lot of laser cases for our, but when we talk about the complete, it is a branch which is coming up a big time. It is a well-established branch. So thank you again for letting us, letting me, give inputs to whatever way we could help in understanding vocal cord paralysis. But today, my highlight was learning from Sherlin. It was really something which I also learned. And till the time, as you said, that you are telling them to go to speak, you can also tell them in the ward that what you can do and all that kind of stuff. So thank you, Sudhi, and thank you to the whole team, and excellent effort. And, looking forward to sometime again interact if possible. Thank you.
Certainly. Shirley, would you like to say something? Like, thank you very much, first of all, for giving your precious time. I know how busy you are as a mother, as a professional.
Ma'am, I just want to thank you for giving me this opportunity. It's not like what and it was my privilege to be able to, share my experiences, and even I'm also learning. In depth, I learned a lot today, and it was a great, like experience. And I'm not into much public speaking and all. So sometimes it happens, like, look, I'm not able to, you know, give whole of the information. But yeah, it was nice, and you gave me the opportunity to demonstrate and practically make you understand. That is how what we work, and I hope I'll get more opportunities from you. And Dr. Bhavna, really, I was really amazed to listen to you today, and
Thank you.
I was really thrilled to learn, and the way of your presentation was really enlightening. And
Thank you.
ma'am, it's hats off to your team and to you. You take so much effort also,
Yeah,
to overall educate and to word of experience, education, and everything you're trying to share to everyone. That is a great step, ma'am. So, congratulations for that. And I
Thank
look
you very
forward.
much.
जब भी मौका मिलेगा मैं जरूर आऊंगी.
exactly.
Certainly, certainly. And now I reveal the secret. This is my hidden agenda to learn from others. So, and through this, like we just learn from every month. We learn something new from the experts like you. And with this, with a glad heart, happy heart, I would like to bid a very good night to all of you. Now I am
Good
closing
night.
the meeting, and with the promise that we'll be meeting in our another meetings just like this. Thank you very much.
Thank you so much.
Thank you,
Thank
ma'am.
you.
Thank
Thank
Bye.
you.
you.
Good
Bye.
night. Good night, everyone.
Well,
Thank
good
you.
night.
Bye.